think chairperson should initiate the discussions, first of all, by seeing the chat box and question answers for next 15 minutes.
Thank you. I don't see any questions pertaining to this. Dr. Raman just wanted to mention use of statins in relation to heart failure is definitely useful in preventing cardiovascular disease and heart failure. And also has been shown by WASCOP study where we have 20 years follow-up, where it has reduced the heart failure risk by nearly 35%, whether the patient had MI or no MI. So it has got additional mechanisms of reducing the risk of heart failure other than preventing MI. Is that right, Raman?
Yeah, that's right. There was definite reduction of 35% of heart failure hospitalization in WASCOP study in 20 years. In ischemic heart failure, it does prevent chronic myocardial ischemia, so it prevents myocardial damage. So at least progression of heart failure will be, prevented in especially in ischemic heart failure. But how far it is going to do it in non-ischemic heart failure is still not known. But maybe some of the pleiotropic effect, like it has an anti-fibrotic effect, anti-apoptotic effect. So they may improve diastolic function in patients, and improvement in diastolic function will make definitely it will reduce symptoms in patient with heart. It may not reduce mortality, but symptomatically patient will be better.
Extending this to the other lipid lowering agents, do you have any data on other non-lipid lowering agents like PCSK9, ezetimibe, and heart failure?
PCSK9, there is a controversial, mechanism, pleiotropic effect. We still do not know whether PCSK9 has a pleiotropic effect or not. And as such, we do not have data that it will can be used as a drug for in heart failure to prevent progression of heart failure, and that to non-ischemic heart failure. Ischemic justified because it is going to lower LDL cholesterol and going to prevent myocardial damage. But main issue comes when the cases of non-ischemic or very advanced ischemic heart failure, because then time is an important factor. Because if you lower LDL cholesterol, it takes time for atheroma to stabilize and to regress and to increase myocardial perfusion. So time is important. Timing is extremely important. So we can use biomarker for that, like NT-proBNP if it is less than 868 picogram. So that may be a useful biomarker, and even galactine if it is less than 19 nanogram. So the marker we can use to use for indication of LDL lowering drug, because whatever the mechanism drug may be, if it lowers LDL cholesterol, it is going to reduce coronary events and going to reduce MI or silent ischemia.
Dr. Prakash, thanks for that excellent talk. And I just want to know, do you have anything to say about the use of digoxin in heart failure?
Sir, digoxin is a drug which can be used in heart failure. One of the indications is when you have atrial fibrillation with heart failure. And the other, of course, is when you have valvular heart disease, atrial fibrillation with heart failure. It's a drug which has been virtually put into disrepute because of one of few trials. But I do use this drug not for basically improving the heart function, but more for reducing the heart rate in those people with atrial fibrillation. It's a good drug to use when, in particular, in atrial fibrillation. Now, whether it has got any harmful effect, I think it's debatable. I really don't think it has got harmful effect. Yes, the problems may arise if you are using diuretics and you are using digoxin, and you can get more of arrhythmias. Well, you need to keep a check on the potassium levels. And definitely when you're exposing the patient to ARNI and MRAs, the chances of hypokalemia become much less. But it is a drug which can be used. I think we can use it, and particularly in those people who are not affording, where ivabradine sometimes, well, I don't know whether you should use it in sinus rhythm. There is no data about that, but can be used when they can't afford drugs like ivabradine. All told, the treatment of heart failure becomes quite costly, and one should try to reduce the cost wherever possible, not at the cost of the benefits of therapy, however.
Dr. Rupali, I have a question for you. See, you have spoken about biomarkers in heparin reduced ejection fraction. So you know that there are so much of imaging modalities available and which plays a vital role in the diagnosis, etiology, subsequent therapy, monitoring, everything. So my question to you, at what stage and when you will do these biomarkers and what are the false positivities?
Thank you, sir. Actually, the biomarkers levels which we clinically normally use are the NT-proBNP levels, because that are easily available and they are reproducible also. So what is shown in the slides also, first at the level of the diagnosis, like when the patient comes with dyspnea, for the diagnosis, these patients should undergo these cardiac biomarkers in the form which is commonly available to us are the nitropeptide levels and the troponin levels. Plus, once the study have shown the pre-discharge nitropeptide levels, they again have better prognostic stratification in these patients. If the pre-discharge levels are on the lower side, they have a better mortality and morbidity benefit at the end of your 6 months to 1 year studies. For guided therapy, I don't think that we have to modify our drugs according to these nitropeptide levels or the different levels. One study which I showed was the measurements of the ST2 levels in these cases. They have shown that ST2 levels, when you measure in these cases at the end of your 14 days or 60 days, they have a prognostic or risk stratification, because they tells us about your fibrosis, they tells about your arrhythmia assessment. That cases can be done. But for a clinical setup, I think peptide levels at the admission and the pre-discharge are still the main therapy, guided therapy in these cases, sir.
Dr. Mahapath, can I comment a bit on this particular aspect, if you don't mind?
Yes.
We have done in our institution studies on ST2 in chronic and acute heart failure. And what we have found is, particularly in de novo heart failure, the acute heart failures or acute coronary syndromes, ST2 levels, if they are high initially and repeat them after about 3 months, if they are showing a reduction, it is definitely helping in the long-term prognosis of these patients. So we have done this study. It's a small study. It was actually a thesis for some of our students, and it has been conclusively shown that ST2 levels can benefit in this perspective. The more important thing is checking out the ST2 levels in those people who have undergone chemotherapy, which has been cardiotoxic. Now, these people, if supposing your ST2 levels are high, more than 50, 70, 100, it is a bad prognosis for these patients. However, if they are high and after a period of about 2 months, they have come down, then there's a chance that the patient will benefit and that the remodeling will be better in these people. We are facing this problem in cardio-oncology. We are facing a lot of this, particularly those people exposed to adriamycin and in some people who have been given other drugs also. So this is one thing which is important. I think monitoring of ST2 is important here. The other aspect which I wanted to about Dr. Rupali is, what is your thought on this factor? You admit a patient with acute decompensated heart failure, do a primary NT-proBNP level. It is high, say 10,000, which is not very uncommon. But you repeat it prior to discharge and you still find it at 5,000. There have been studies which have shown that these people have a worse prognosis and higher chance of repeated hospitalization. So maybe in those people who are coming to us with very, very high levels of NT-proBNP, it would be more prudent to repeat the NT-proBNP prior to discharge and then take a call whether the patient requires more regular follow-up or more frequent follow-up.
I agree, sir, because that also mentioned in the study. And we did a small study from our institute also about a 60-patient study around 3-4 years back. We checked the different pre-discharge at admission at 24 hours and pre-discharge levels. So what the prognosis, when we followed it for 6 months to 1 year. So I agree with you, the pre-discharge levels came out that when the pre-discharge levels still are not very high, are still very high, they have a bad prognosis in terms of a rehospitalization rate and the mortality. So totally these patients should be managed very aggressively in these cases in the terms of your diuretics, or the decongestion should be done more effectively in these cases. The second point of ST2, I showed a slide also. The ST2 score is also there. If the score is 48 nanogram per ml ST2 levels, they have a good remodeling, reverse remodeling in these cases. So because this is, ST2 is basically tells about the fibrosis. So there are various studies which have correlated ST2 levels with the cardiac MRI also, showing the fibrosis and loic gadolinium enhancement in these cases. So ST2 definitely its availability, it's more a localized thing, not really available. So I didn't mention, but it was a clinical point of view. But definitely ST2 for reverse remodeling, and the prognosis is better in these cases. Sir.
I agree with Dr. Rupali. I think very nicely answered. There are I was just going through the Biostat heart failure study where they have looked at 363 biomarkers. So there are different biomarkers which will tell us about the diagnosis. Some are good at diagnosis, some are good at prediction. With the heart failure reserve ejection fraction, some are the residual ejection fraction. And also, as Dr. Bali mentioned, these are biomarkers that are affected by age, BMI, renal function, and inflammation, etc.
If there is no question, can you go to the second sessions? Any question is there, chairpersons? Dr.
May I ask? Dr. Mahapatra, may I ask?
Please go ahead.
Yeah, I have question to Dr. Raman. The statin prevents the production of particular beneficial and productive factor such as coenzyme 10, while inhibiting the production of specific protein involved with the pathologic mechanism, so lead to heart failure. So what is your opinion about this notion? Hello.
Dr. Puri, please unmute yourself. Dr. Puri. Yes.
Dr. Puri. Can I repeat if you want?
Dr. Puri, please unmute yourself. Dr. Raman Puri, please unmute.
Is it okay now?
Yes.
Absolutely, it's a valid question, and this is one of the possible explanations for heart failure patients who are on statin. But there are no studies which have shown improvement of ejection fraction or LV function improvement with supplement. So, in case you just want to add this medicine, one can add, because there are small studies which have documented also, but there are no large RCTs which have shown beneficial effect of adding this drug to the treatment to improve heart function. But definitely this is one of the possible explanations.
Dr. Puri, there is a new thing which is a modified coenzyme Q. It's called MitoQ. And many places, particularly in New Zealand, Australia, it's been touted as the panacea for those people who have this acute decompensated heart failure de novo. What is your idea about that? Because there's just one or two studies I've come across. It's called MitoQ, produced in New Zealand and Australia. Dr. Iyenger, anything about, you're smiling there, so I'm asking this question.
You always come with difficult questions. I have no idea about this.
Even I don't have any idea. If you have something, please let me know.
No, because this is what has been advocated for these people, again, in the cardio-onco field, that when you start these people on adriamycin and they tend to have a drop in GLS or a slight drop in ejection fraction, you can start them on MitoQ, and, well, the drug is costly, it's not easily available, and you require high doses, but it is said to be beneficial. That's the reason I asked you this question. Anybody else who has got any knowledge, and please enlighten me.
Only one
I've
thing.
been using coenzyme Q. I have no much idea, because one, regarding the availability, just one of the two points which I wanted to make was with regards to what Dr. Sansgiri had mentioned. Like many of our colleagues in United States keep even chiding us that do you still continue to use digoxin? It is the same question like, are beta blockers, they have any role in hypertension? We say, because we are a adrenergic state, it is one of the important drugs. Same way, even digoxin, we continue to use, because many a time, in spite of giving beta blockers, when the BP really falls, the patient is having almost decompensated heart failure. I have found digoxin to be useful in controlling heart failure. There was, I believe, one trial, I forget the name, Radiant or something, where it is, although conclusively proven that it does not reduce mortality, but definitely it brings about a symptomatic relief. And that is what is important. We do not have to think about that I give digoxin for mitral incompetence. Most of our patients with severe dilated cardiomyopathy have got mild to moderate MR and a good amount of TR also. So I believe it has a use. Only thing, sometimes once in a while we do serum digoxin levels, because there are enough studies to show that 1/3 of the patients, would have silent digoxin toxicity. The level mentioned in books is 200 micrograms, but once I reviewed long back, 110 is what we should look for as a safe level. And for Dr. Rupali, we do find, I'm involved in many clinical trials, and they talk only of pro-BNP. Whereas, of course, I understand when it is in atrial fibrillation, you must use only pro-BNP and not BNP. But in real life situation, I suppose the cost of doing BNP is much cheaper than pro-BNP. And many times patients come with from one lab, one report, and other lab, one report. So we do not have correlation. So which are the cases where you would, besides atrial fibrillation, you would want to make a choice between BNP or pro-BNP, because there are many physicians in this group?
Sir, actually, with BNP and anti-pro-BNP, the cost is not much difference. If you see, there is hardly a difference of about 210 rupees. The only thing now, if we see that is the BNP levels are affected by many things. Suppose renal dysfunctions patients, they will have a very high BNP levels. Especially now in setups, if the ARNI is given in these patients, you will always try to avoid doing BNP in these cases because BNP gets degraded by neprilysin. And when you give a neprilysin inhibitor, they falsely elevate these BNP levels. So monitoring, especially if the patient is on ARNI, and if you suspect that these patients are having atrial fibrillation, it's better to go for these anti-pro-BNP levels. But according to in our lab, actually, it's not much difference between the cost of BNP and anti-BNP. And second is a half-life. That is the basic challenge, because that you have to do a bedside test of BNP because the half-life is only 20 minutes in these cases. So that should be kept in mind whenever we take the sample in these patients.
What is about ANP level in atrial fibrillation? ANP?
So ANP, actually, the availability ANP issue again becomes an issue because we don't have very freely available ANP levels to be done in the cases.
Thank you, all the speakers like Dr. Raman Puri, Dr. Prakash Sansgiri, Dr. Rupali Khana for your wonderful presentation, state of the art. And also, I am really thankful to our eminent chairperson, Dr. S.S. Iyenger, Dr. Vinod, Vijan, Dr. S.K. Parashar. So with this, we conclude this session.